Hi, this is another scenario. This is a 76 years old woman who presented to outpatient department with a painful right knee. She had an index surgery 16 years ago with a right knee replacement. So, right total knee replacement. So, tell me what do you see and what's your diagnosis? So, this is a clinical photograph of this lady showing a very small alignment of her right knee. There is a midline well healed scar indicating for her previous surgery. uh, for the X-rays showing a ghostly loose TKR with a failing of the tibial and femoral component. I can see a gross malalignment on the femoral side. There is a valgus malalignment of the component. On the tibial side, there is a very small alignment of the tibial component with a periprosthetic fracture on the medial tibial plateau. On the patellar side, I cannot see a loosening of the patellar pattern. So I would like to take a detailed history from this patient as regard her condition. This can be septic or aseptic loosening. So history include history of the present complaint, ensuring the pain is originating from the knee. History of red flags that can suggest a serious pathology like infection. I will do an Oxford knee score, treat what's the treatment received and what the outcome, and what's the patient limitations and expectation. Past knee history include the history of the index surgery, indication, duration, perioperative period, and outcome. Other joint history, including if she had any other replacement, especially if she had an ipsilateral hip replacement. I will ask about past medical history, how fit is the patient, and if she had any history of immunosuppression and history of smoking. I will do my examination looking for general, the BMI and overall alignment. Local, I will look for the skin condition, scars, alignment in the three plans. I will look, check her gait, check her extensor mechanism function, feel for point of tenderness and diffusion, check range of movement and the stability of the implant and the correctability of the deformity. I will check her hips and examine the spine and the neurovascular status. I will proceed for investigations. I will do a plain radiograph for the knee full with bearing two views, which I have, but I will have a long leg alignment view. I will compare that with previous radiograph for previous radiographs. I will do a CT scan to check how much is the bone stock and do a preoperative planning. For laboratory investigation, that's based on the British Orthopedic Association Guidelines 2020 and the International Consensus Meeting for 2013 for peripatetic joint infections. That include basic bloods, full blood count use and ease. I will do inflammatory markers to exclude infection. And if any suspicious, I will do a range for knee aspiration theater under complete aseptic technique. The aim of treatment of this condition is I need to achieve, first of all, I need to meet the patient expectations and to achieve a pain-free stable knee with restoration of the alignment, joint line, and the patellar tracking and the balanced gap knee. The guidelines and evidence is from the British Orthopedic Association revision TKR guidelines issued in 2020, and the principles that such complex cases need a discussion with the regional multidisciplinary team network for revision total knee replacement. The options can be non-operative treatment, assuming that patient had a non-operative treatment and that had been exhausted. Patient is symptomatic and fit enough to proceed for surgery. Will be a revision total knee replacement, and that should take place in by a specialist center on a specialist center or at least with a specialist knee revision surgeon. And the principles of that is pre-operative planning. I need to exclude infection, implant removal in very conservative man, bony conservative manner, and the reconstruction option with a wide variety of implant should be available to address bony defect by bone graft, wedges, augments, sleeves, cones, and it sort out instability as well. As a specific challenges appropriate preoperative planning through anesthetic review to optimize the patient prior to surgery, senior knee revision surgeon to get it right first time, and preferably a dowel consultant operating according to the guidelines. Intraoperative, the steps is by exposure, implant removal, and reconstruction. So exposure should be have a longer incision, extended medial parapatellar approach, doing synovectomy all around the knee, cleave the gutters, obtaining samples for microbiology examination, and so a tibial tubercle osteotomy should be an option if we struggle to expose the knee. I will start by careful removal of the implant by a sequence of pulley first, then the femoral components, then the tibial and the patella at the end. Then we're starting reconstruction, starting with the tibial side. Tibia is the foundation for the whole construct. Accurate assessment of the bone defect and reconstruct accordingly. Restore the joint line, obtain a stable base plate. On the femoral side, I restore the posterior offset, avoid malrotation. I will balance the flexion and extension gap. Then I will turn it toward the patella during the revision if the patella component is loose. Post-operative, I will do routine post-operative rehabilitation.